I'm going to introduce Dr. Parker Oliver. Dr. Oliver is the Ira Codner Endowed Chair at Washington University in Supportive Care and Research at the Med School. Dr. Oliver has her master's in social work and a PhD in rural sociology from the University of Missouri. The remarkable thing about her research career is that it is grounded in over 20 years of practice in the field of hospice. She actually founded a hospice program in St. Joseph, Missouri, and has directed hospice programs for over 20 years. She then got into research in this important area and has had the most successful career in that. And that's why WashU sought to recruit her several years ago. It was remarkable on her CV that she is the first non-physician member of the board of directors for the American Academy in Hospice and Palliative Care. She's been continually funded for many years by the Institute of Public Health. She's going to describe some of her work today. She mostly focuses on clinical trials, developing interventions to improve hospice caregiving experiences, lowering caregiving anxiety and depression, and improving patient outcomes. Today, she's going to talk about her experience with telehealth, digital disparities in older adults, the challenges and need for inclusive technology. We're really glad you're here with us and given this time today, Dr. Oliver. So with that, if you want to get up your slides, we're ready.
All right, that's great. I'm looking forward to sharing one of our new projects with everybody and hearing your questions and your feedback, and that'll be a win-win. So we keep this kind of informal. We're working primarily with caregivers and older adults, and we're developing what we call a PO1, which is a large center grant that will have 3 interventions inside of it. And I'll be describing all of those today and walking you through that. Now, if I can get my slides to advance, there we go. We're going to focus on understanding what I mean by digital inclusiveness and digital disparities, and take a look at the impact of those items on older adults as they try to access telehealth technologies, and then identify some opportunities to improve telehealth interventions to be more inclusive. And I'll use our work to kind of illustrate that. I'm not sure how much everybody knows about caregiving, but caregiving in the United States, most recent data is from 2020, is kind of a gloomy tale. And it continues to worsen and grow. Basically, our healthcare system is built on the backs of family caregivers, which assumes that everybody has a family caregiver that is willing and or able to provide that kind of care within the home setting. And of course, when it goes wrong and when it fails, that means people end up in the hospital or long-term care facilities or other institutional settings. We estimate there's somewhere around 53 million caregivers, family caregivers in the United States. That's about 20% of the population. So nearly 1 in 5 are providing unpaid care to some kind of an adult with limited health or functional needs. Many are caring for more than one person, and that might even be more than one generation. Family caregivers report having terrible difficulties with coordinating care. The latest fad is to come up with digital navigators to help people do this, and even this, or with navigators, and even that in our health, I like to call it our health non-system, creates all kinds of stress and challenges. Specifically, we're going to talk about Alzheimer's disease, and more Americans are caring for people with Alzheimer's disease or dementia than anyone else. And it's really important to understand that family caregivers report that their own health is impacted by the care that they receive. We know that those that are caregivers as compared to those that do not ever caregive have a shorter mortality and they have more chronic diseases as a result of their actual caregiving. Specifically with Alzheimer's disease, we estimate there's about 16 million Americans who are providing about 17 billion hours of unpaid care each year for persons with Alzheimer's disease. Family caregivers have been shown to be at risk for burden, stress, depression, and other health issues. The research is so clear on this that if caregiving could be a diagnosis, it would be. It is prevalent, it is problematic, it is expensive. The negative effects are well documented. There's an entire science around caregiving. Interventions are well documented, but efficacious interventions that are scalable and widely disseminated and implemented are very rare. What we have is a lot of, it's kind of the classic D&I case where you have a lot of research that's being done, a lot of testing being done, but not a lot of it is actually being driven down and actually hitting the population that it's meant to serve. It's actually now got such a reputation that in September of 2022, and that's just a couple of months ago, a few weeks ago, actually, the Health and Human Services actually issued a national strategy on caregiving, a great document that we were very excited to see. It's for the first time a large acknowledgement that we do have a problem in the United States. It identifies that problem, has a lot of great things included some solid principles, some diversity and cultural sensitivity components, all of those things that you could ever want. The problem is that it's not grounded in much of the research that's done, nor are the solutions that are proposed very concrete. What you see is a whole lot of agencies that are pledging to collect more data, which further describes the problem. I suppose that's great, but we already know we have the problem, and we know it's a big problem. It would be nice if we saw some more energy expended to solving the problem. And that's where, believe it or not, the National Institute of Aging is actually leading the way in this report. I looked through it. I couldn't find a single other NIH institute that had pledged to try to solve this problem with research. But the National Institute of Aging has promised more caregiver research in response to this report. So we're really excited about that and find that really timely for the work that we're trying to accomplish. We have found that technology actually can help with these problems. We have been working now for many years in trying to bridge the geographic distance between caregivers and healthcare providers and support systems and family support systems, connecting stakeholders. Believe it or not, even prior to the big rampant use of the internet, we were doing this 25 years ago using video phones. Matter of fact, that's how the research I was doing when I met Nancy through the Hartford Foundation a gazillion years ago. And so seniors are learning how to use the internet. They're becoming more proficient. And of course, with the onset of COVID, it really spiraled. What was actually innovative at that time has become kind of routine. And it was right in the middle of a clinical trial we were doing when COVID hit, and what was seen as, well, I'm kind of afraid of this web conferencing Zoom stuff, and a barrier to recruitment actually changed pretty dramatically. We know that technology increases the access to information, it facilitates communication, and many, many telehealth applications actually can support and encourage that, and support and encourage engagement, and is now being used to facilitate many, many different kinds of intervention. Everything between YouTube videos and Twitter and Instagram interventions and Facebook interventions, Zoom-based interventions, you name it, and technology is kind of leading the edge. And that technology can be great and it can expand access. However, we also find that while it can introduce those significant benefits, it also has the potential to further exacerbate several kinds of inequities that are faced with by people with limited ability to access the technology or infrastructure. And a great successful intervention is only as good as an individual's ability to access that. And with older adults especially, we have that issue. For instance, if they cannot access their EMR, like my parents, they're at a great disadvantage because we're doing so much on the EMR, and then you want to report, you want to know what your lab results are, you want to schedule appointments, you can do all of that online, unless you're unable and or unwilling to do that. And my 84-year-old father says, I've lived all these years without the computer, I don't need it anymore. So he burdens my mother with accessing that. And if she's gone, he has no access. So trying to figure out how we bring access to individuals who have limited enthusiasm and or ability or are afraid of the internet becomes a real problem when we're trying to implement specific interventions. Got some definitions that I'd like to just kind of make sure we're all on the same page. I talk a lot about digital inclusion, and that is activities that are necessary to ensure that everybody, including disadvantaged, have access and can effectively use digital tools. We actually are finding less access issues, especially given the power of the cell phone. I mean, my goodness, the power within this phone is greater than the power that were in the original computers that I used to design interventions. So a lot of people now have access through expanded internet, broadband, even in the rural areas. We're not finding access to be so much of a problem as we are the ability to effectively use the digital tools. And that's where we get into digital, what we call digital disparities. Those are the barriers to use of those digital tools by any group of individual based on some common traits, be that age or rurality or race or digital literacy. And we'll talk a little bit about digital literacy here in a minute. But what we're finding is that actually digital inclusion is becoming a social determinant of health. And addressing it can have the same kind of positive effect as addressing any other social determinant of health when it comes to building and designing interventions. We've just completed some preliminary work on digital literacy. We were able to get a supplement to a social media intervention we were testing using Facebook with caregivers of hospice patients. And we were trying to figure out for those individuals who did not want to participate in our intervention or who struggled because of their inability to use the Facebook platform, how can we use that information and design that information in order to improve the intervention? You know, it does require cognitive and technical skills in order to communicate that information. And we find that the effect of digital literacy on participation in especially social media clinical trials in cancer, which is what we've been doing, that older adults rated themselves as more proficient, were more likely to participate in those media trials. And we're talking about Facebook specifically. And if we could assess their digital literacy and tailor our consent process and that assessment, we figured we could actually increase the access to clinical trials with older adults. So after doing some work, we were able to figure out, basically we only need 2 questions to assess an older adult's digital literacy. One is to ask them to rate their skill in the use of computer or cell phones on a scale of 1 to 10. And if they respond with a 5 or lower, they're going to be less likely to participate in the study. So we need to provide them with some extra coaching in order to make that happen. And then because we were using Facebook specifically, we asked them to rate their skill regarding Facebook. Actually, they were less fearful of Facebook than they were computers. Interestingly enough, we found that individuals may be using Facebook and not realizing that that is even on the internet. They'll have it on their phone, maybe their grandchild or some younger member of the family put that on their cell phone as an app. So all they have to do is is click on it. This would be my mom. And not even realizing that they're on the internet, but they know that they can see what's going on with their family by accessing that. So it's kind of interesting. There's actually been over 100 studies that have looked at the disparities within digital health tools. And that would include such things as the use of the electronic medical record portal that we talked about. And that those disparities are based on age, race, socioeconomic status, and all of the other social determinants of health that you can imagine. I have a 12-year-old puppy who's decided to chew on my feet if you happen to see me jumping around. Just my luck. Okay, now my slides decided not to advance. Here we go. The premise for this project that I want to share with you is that digital disparities require us to take a look at telehealth systems and make them more inclusive, recognizing that there's a range of abilities and there's a range of preferences among users, and that we design the interventions with them to reduce the overall physical and cognitive burden. And that's a whole science that's emerging in and of itself. For those that went to GSA this year, it was my understanding there was a lot on inclusive telehealth offered at GSA. You're starting to see a lot of it in the literature, and these are terms that are emerging. So the time is right to really kind of take a look at this. The goal of our new proposal I want to share is that we advance these interventions that have already been tested for caregivers of patients specifically with Alzheimer's disease, since that's the majority of caregivers in the country, by addressing these digital disparities with what is more inclusive telehealth technology. So what are we proposing? The title of our project grant is called Fostering Digital Equity Through Inclusive Telehealth Interventions for Family Caregivers. And what we want to do is maximize the inclusivity of 3 evidence-based telemedicine interventions for caregivers of ADRD patients. These are interventions that we have already tested previously. And what the requirement of a program project grant is that you can bring together 3 projects, and they create synergy and create potential for future research in ways that if you had individual funded R01 projects, that couldn't happen. So specifically, as we look at doing this, these telehealth interventions with caregivers, what we're able to do is create a much larger database by bringing together 3 projects or 3 studies under one umbrella. And thus we'll be able to do more around social determinant of health specifically, because we'll have a larger combination of racial and ethnics and social determinant of health variables. We'll be able to ask research questions that are greater than just what one project will be able to do. So what are our projects? The first one we call Pisces Web. It's actually a self-directed, web-based problem-solving intervention for caregivers of Alzheimer's patients. And we have been testing this actually in 2 other clinical trials and found it to be very effective, but it's not been web-based. It's been delivered in person, including to caregivers of ADRD patients. And we've been successful at improving the quality of life and lowering the anxiety of caregivers when we make them better problem solvers. Problem-solving therapy has been around for a long time. Those of you that are in social behavioral sciences are probably quite familiar with the model. And what we do is we take them through the problem-solving steps so they learn to systematically solve those problems, brainstorm solutions, draft and prioritize those solutions, and finally implement them and then evaluate their success. We're wanting to do this now online because it makes it more scalable. So we've been doing this in hospice specifically. We're going to open it up and take it upstream into early diagnosis. But it's just not practical for healthcare providers, regardless of their backgrounds. to actually spend the time to do this with caregivers. And our minimum amount of pilot work we've done on this says that there's a way that if you have a very interactive web-based, that you can be more digitally inclusive, because you can make that solve a lot of problems around hearing, sight, visualization, understanding. So by doing it on the web, you have that advantage. And then of course it's more accessible, and it's not dependent upon matching your time and the time of a healthcare professional all at one time. PICE stands for Problem Solving Intervention to support caregivers in everyday situations. We're going to use video tools, and actually they're kind of amazing because we can program this lady who we compose, the facilitator, all we control that, make sure that they're ethnically diverse. We can choose their language, so that if somebody is Spanish speaking or has another language, we can change that. And this avatar, for lack of a better term, can present the material that normally we would present by a live facilitator. So we will be using those tools. We're able to, because we've got a mass quantity of real life examples in our previous research, use those avatars with real life examples from caregivers, so that we know that they're easily relatable examples to help them learn these techniques. We're going to focus on improving caregiver self-efficacy and communication with providers, because we know that that's a problem. They are uncomfortable, they lack confidence in their communication with providers, and we want to teach them how to be better advocates for themselves. And in turn, our research has shown that we reduce both depression and anxiety with this intervention. So hopefully we'll be able to do that also in using this digitally inclusive, self-directed, web-based platform, rather than a one-on-one platform. So that's project one. Project two is led by Dr. Washington. I'm very excited about this. It's a web-based symptom management tool for families of Alzheimer's patients. What we do is family members are trained to document and assess symptoms that are then communicated specifically to hospice staff using a web-based tool. Right now, hospice teams gather every 2 weeks and have interdisciplinary conferences where they set the goals for the patient for the next 2 weeks. And again, these will be Alzheimer's patients that are within a 6-month prognosis. And the hospice teams are kind of working in the dark, because while individuals on that team may have spoken to the caregiver's voice is not represented. We've spent the past 4 years trying to introduce the caregiver's voice into those meetings and found all kinds of problems. It's not a feasible solution. So now we're trying to introduce them using these digital tools. What it is every day, a caregiver will receive a prompt and put into the system their assessment of the symptoms of the patient. And then that information is automatically communicated to the hospice staff. It's also compiled into a dashboard, so that as that team meets all together once every other week, up on a centralized screen, they'll have a digital visual display that the symptoms are getting better or worse, and kind of some basics about the caregiver. One of the really cool things we want to do is carefully select the photos that go on that site. And we've done a lot of preliminary work about this. Hospice teams spend a lot of work talking about things that can be visually displayed about a caregiver. So for instance, if it happens to be a caregiver that is taking care of 100 cats as well as their family. Now my puppies are really having a good time here. Then what we'll be able to do is take a picture of the caregiver surrounded by her 100 cats, and the team will automatically get the idea of what that environment is. You know, a picture's worth 1,000 words, and there's a lot of ways that we can convey important information about family caregivers or patients just through a picture. and that will appear on that dashboard. We have already done some preliminary testing and again found that by participating in assessing these symptoms, caregivers increase their self-efficacy with symptom management and communication with the team. And that, of course, results in improved caregiver anxiety and depression. As we know, there's a direct link between self-efficacy and those two things. I thought I had a picture of that digital dashboard, but it looks like it's not happening. Great. And we already talked about that, so my slides somehow got moved. Here we go. Here's a picture of it. Originally, we started out, we've used a lot of stakeholder engagement to come up with this dashboard, and this is just a prototype right now. Caregivers will answer daily questions, take less than 5 minutes, and all of that information is fed in and fed into the hospice team so that when the caregiver and the patient are coming up for discussion, they have something like this. And you can tell immediately that there are two problems that need to be addressed in this particular situation. The patient is tired and the patient is experiencing a lot of anxiety. And we also see that we're starting to have some creeping problems around drowsiness, nausea, depression, and problems with their well-being. We also included a caregiver tab. I have to say, much to the lack of excitement about that from hospice teams, just because they're not used to it. But we're assessing with this measure caregiver depression, anxiety, insomnia, and their overall well-being. And you can see that the caregiver here is starting to get a little bit of anxiety. What this does is at a glance, it helps the hospice team know where to start focusing their discussion. It's important to realize that a discussion in this is a required team meeting the hospice team has. The average length of time they talk is 5 minutes. And right now they have no structure around how to prioritize and quickly identify those problems. So what happens is the discipline with the most power or the strongest advocate ends up being the one that drives what the discussion is, rather than what the patient and family's perceptions of their problem was. This is all built on family generated data. And so these are the problems that as the family is seeing them. And that's the reality when you're delivering family-centered care. The third intervention is one that I led some work on earlier. It is called the FIND intervention for family involvement in nursing home decisions. This intervention uses basically 3 intervention strategies with caregivers of Alzheimer's patients that are in long-term care facilities. First is we train families and the nursing home care plan staff on the problem-solving intervention. So we'll tie it back in to the Pisces web so that they have a common language on how to identify problems, how to have a process to solve problems as they get together and meet. Quarterly, it is required by regulation that nursing home teams come together and create a plan of care for every resident. What we do is invite the families to attend that session, and we're trying to give them a common framework by which they have those discussions. When we did this before, we found one of the problems that were not inclusive is the nursing home environments for web conferencing. Okay, maybe they had internet for billing, but they didn't have good internet for any kind of other activities within the nursing home setting. Or maybe they did, and there was some web conferencing going on. Now there's, of course, a whole lot more after COVID, but the infrastructure within the bandwidth wasn't good, the sound wasn't good, the lighting wasn't good. So what we know we need to do is come in and take an assessment of that environment and really change the environment so that there can actually be a good two-way dialogue. And that's part of making the telehealth intervention inclusive. Families then attend those quarterly care plan meetings and they participate in that. And we're hoping that that will improve both the communication with the staff. It will cause the caregivers less anxiety. Our preliminary work showed that family members were less depressed and had higher satisfaction with nursing home care as a result. So these 3 projects, in addition to being 3 complete clinical trials, really great things about them is that it's a multi-institutional program. It's a partnership between the University of Pennsylvania and WashU. Dr. George Demiris and I have been working together for more than 25 years. So as multiple PIs, we know how to work together and we know how to collaborate. And both of these universities have rich resources in our ADRCs for Alzheimer's research. So that gives us a strong background. We also have backgrounds in sociology, gerontology, social work, medicine, nursing, family science, informatics, and computer science. So we're bringing together a large team between 2 strong institutions in order to make this project work. We're also doing across settings. When you do one specific project, you generally have to focus on a setting, be it long-term care, the clinic setting, palliative care, hospice. Pisces Web is going to focus on early diagnosis, and then we're going to modify that in the long-term care setting. Envisioning Care, or that project with the dashboard, will be hospice specific. And then Find is nursing home specific, all with caregivers and family members of persons with Alzheimer's disease. So what do we need to be successful? We've got to do digital literacy assessments, and we've got to figure out how to tailor these interventions based upon the findings of those assessments, so that not only can the very proficient use them, but those that are not can also. We're also going to have digital navigators, and our trick here, these individuals will be able to help family members, staff members, and solve a lot of the technical issues. That's part of how we're going to get around digital literacy issues. But of course, how does that become sustainable when this gets implemented into the real world? Would people pay for digital navigators? And actually, I'm beginning to think yes. Just anecdotally, my parents, for instance, and my in-laws, they all purchased the Geek service from Best Buy, and they're notorious for taking their technology in whenever they can't do anything, even remember what their password is, and they go in and these blessed people walk them through these problems. And this is kind of a similar model. And so as seniors become more aware that the benefits that are reaped by this, we're kind of wondering, would they even pay for this service? So that'll be part of what we're assessing. Of course, we want to do inclusive design of all of these different tools and figure out how you measure this new term, inclusive technology. How do you know if something is inclusive or not? We're trying to design the interventions so they are what we call maximally potent, so that we end up not with just statistically significant change, but clinically significant change. That requires us to really target in and focus on what are the mechanisms of change within this intervention that impact those outcomes. And then, of course, developing interventions which are scalable and doable out into the real world. So with that real quick oversight, I hope you have lots of feedback and lots of questions, and we can just do some sharing.
Great, thank you so much for that wonderful presentation and sharing all the great work you're doing. Looks like we do have one question, and if anybody else has a question, feel free to either use the raise your hand icon, and then we can just call on people, or come off camera or mute, or put them in the chat box, which can be found on the main menu at the bottom there. So the first question is, can you talk about some of the outcomes you've seen so far with some of these digital interventions and how they compare with face-to-face interventions?
You know, that's a great question. I've been amazed at the impact on mental health outcomes, anxiety, self-efficacy, depression, especially. We just finished a clinical trial with Facebook, as I said, online Facebook support groups, and had an impact with a very small number. It was a significant effect at lowering depression by isolated caregivers who are stuck at home caring for their dying persons and basically don't have that support, especially in the middle of the night. And so mental health outcomes have been primarily what we've looked at. Caregiver burden, caregiver quality of life, another instrument. The Pisces intervention, when we did that, we started out doing that face-to-face and tested that. It had equal effectiveness when we moved it to online and did that as a web-based technology. And we're finding that to be the case. We got to modify things, but people are getting used enough to web conferencing that we're not losing the effectiveness of these interventions, and we're able to do this so much more cost effectively and reach such a broader audience by doing that. But we've looked at several mental health outcomes and had success in all of them. It's a great question.
Great, thank you. Are there any other questions? Feel free if anybody wants to go ahead and unmute and ask.
Either I totally confused you or I answered everything with my presentation, which I doubt.
But I also doubt that you confused. I think it was a very clear and straightforward presentation as well. So I think just a lot of good information to absorb. Looks like we do have a question here. Is the Envisioning Care project looking at CAHPS hospice survey data too?
What was the TH?
CAHPS.
Oh, the Champus stuff. Right now we're starting out with just specific symptoms using the Edmunds symptom monitors, what they're answering every day. And that can change once we get a good handle on the technology and the process. So eventually we'll be able to do that. I have to say that this is the first intervention that we've designed in our team's history where the agencies are lined up, literally lined up, wanting to participate because they're so excited about it. Hospice teams are very, very frustrated around trying to measure things, and these team meetings are very, very frustrating because they last literally for hours as they try to cover hundreds of patients, and they do so with information scattered all over the place. And so as they've helped us design these dashboards and the technology around it, they're all incredibly excited about it, and all knowing that we start with what's easy, and then we can build into what gets to be more difficult, and how the ways they can use that for quality improvement efforts and for mandated reporting and mandated quality assurance reports will still be yet to figure it out, but they certainly see the promise in that.
Great, thank you. Next question. Have you used the outcome of delayed transition to nursing home with digital support of caregivers?
We have not yet, and that's a really good one and one to think about. This will be the first time that we have followed caregivers across the span. Normally our work has been in hospice and in palliative care, or just in the nursing home. So we also haven't used it to look at the economic benefits of if we've prevented hospitalization, we prevented emergency rooms. I've got another project I work on with an investigator at Johns Hopkins where we've created telenovelas that are educational in nature, using dramatic story to educate caregivers. And we have done some looks at were we able to successfully reduce the number of ER visits by caregivers in hospice, because one of the sessions is how do I know when I should take my patient to the emergency room? And we were successful at that. So that's another really, transitions is a whole nother really great, a great idea of things that we can measure.